Here we are. Welcome to London, guys. Welcome to London.
So thanks, Lorenzo. Thanks again for your kind invitation and for the opportunity to present this case. It's a challenge case of BTK-BTA, in which I use the Oscar catheter. Oscar is the new catheter. This is my disclosure. The new crossing catheter from Biotronic that combine a super catheter and a dilator plus a dedicated balloon. Kun, if you have any underline about the device, you are welcome. So the case is about an 84-year-old female with diabetes, dyslipidemia, hypertension, bilateral peripheral arterial disease that she was already treated in the target lower limb and is back for recurrence. In the other side, she has a transmetatarsal amputation. So a challenge patient from the clinical perspective. She's again on the table for the right CLTI. It's a Rutherford 4.5. The TCPO2 is very low, and the Wi-Fi score is 231, with the ulcer in the first and in the third toe, and a clear ischemic forefoot. So unfortunately, I don't have the pictures of the foot. I'm so sorry, but this is the diagnostic angio. I did an access in the common femoral 6 French sheath. You can see multiple stenosis in the proximal SFA and in the median part of the SFA, as well in the popliteal artery, diffuse disease popliteal artery, occlusion of anterior tibial, occlusion of posterior tibial. This is a CO2 angio, and you can clearly see an anatomical variation with the peroneal providing direct blood flow for the forefoot. And again, the anatomy in the foot is quite complex. Don't have pointer?
You go. You have your finger as a marker.
Yeah, okay. First toe, a piece of the arch, no dorsalis pedis, no lateral plantar, so many collaterals. Considering the first anatomical variation we saw, so peroneal providing flow for the dorsal circulation, can suspect some other anatomical variations. But honestly speaking, from the beginning, I didn't realize clearly how was the anatomy. So, first question. SFA and POP is enough. In this case, there are ulcers, superficial ulcers with no deep infection in the first and in the third toe. SFA POP plus peroneal, or SFA POP plus posterior tibial.
So, green flag for SFA POP enough.
You can choose the colors.
Yeah, green for the first, second is going to be red, and the third one is going to be yellow.
Green, red, yellow. Yellow, 1, 2. So, okay, most of you decide for SFA POP peroneal and avoid posterior tibia, and nobody decide to go for SFA and POP. It can be enough. Okay. Well, let's see what I did. I start doing the SFA and POP. She was already treated in this leg, so I did a pleural angioplasty, no reimbursed about anything in Italy. So dissection and still recoiling in the proximal SFA. So decide to deploy stent. I deploy a Pulsar T3, 6 mm proximally and 5 mm distally to block all the residual stenosis and the dissections. Very precise the stent, very easy to deploy, so very safe to fix it, and acceptable result in the SFA and POP. Since I realized the anatomical variation from peroneal, I decided to start with the Oscar 014 platform device and approach posterior tibial. My target was posterior tibial, so 014 guide wire, I was able to enter with the guide wire, with the super catheter, and pushing and rotating a bit the dilator, I was able to step-by-step approach and start to recanalize the posterior tibial.
Can we stop the video, please? Can we stop the video? Just share us with us why you're going for the posterior tibial when it was the peroneal.
Because I suspect a new anatomical variation. So I was able to see the arch finishing directly in the first toe, and this is quite typical situation in which you don't have dorsalis pedis. So no hypoplastic dorsalis pedis, but absent. 11% of the population doesn't have dorsalis pedis. So it was quite clear from my perspective, seeing two tarsal branches, one lateral, one medial, and I suspect the absence of dorsalis pedis. But as I said, till this point, I was not sure about the anatomy, but decided to approach the posterior tibial, even because there was some landing, very distal landing zoom at the forefoot.
We can start the video again.
So, 4 French super catheter, O14 platform device, allow me to enter in the posterior tibial, allow me to do the first part endoluminal, and finally, I decide to make the loop in this Terumo Advantage track O14 guide wire and go subintimal. Not too much calcium, so it allows us to mix between endoluminal and subintimal progression. Good loop, good control, and for sure the super catheter allow to support too much the pushability or the pushing of the wire, as well the rotator, the dilator allow us to support the guide wire and to advance without any problem till the ankle and even in the foot. So from the perspective of Oscar, this is an excellent crossing device that allows us to save money, save time, save contrast, and for sure allow us to reduce the number of devices. One super catheter, the dilator, the time the dilator cross, everything can cross, and with one guide wire, I was able to arrive till the foot. It's never guaranteed 100% to stay in the lumen because it depends on what you decide to do. Since I push the guide wire in a loop-shaped tip, I advance in some segment endoluminal, and the time the super catheter was not able to advance, I used the balloon that is provided in the kit of Oscar to pre-dilate and finally advance the super catheter till the ankle level and even in the foot.
Which size?
Without
3 millimeter?
2.5.
2.5.
2.5. And here we are. The same guide wire, the same Oscar, super catheter at the ankle, dilator in the foot, and now, again, some problems. I suspect to have the wire in the median plantar, but was able to see some calcifications in what should be the lateral plantar. So again, it doesn't want to go in the lumen, so make the loop, trying to be very soft, trying to avoid to damage the artery. You could see finally the loop of the wire pushing the calcifications at the lateral plantar level and, failed to re-enter. So again, no heavy calcified arteries, just spot calcifications in the median part and in the distal part of the lateral plantar, but the device performed pretty well, arrived without problem till the forefoot or the midfoot, but the wire, or myself, I failed to re-enter in what I was able to see from the beginning, a very poor distal landing zoom artery that was not at this point, but was here. So I needed to go ahead another 5-6 centimeters before the re-enter. But I failed the re-enter. I declare I was not able to re-enter. I didn't force to avoid any damage in the distal arteries. And the last question. And now, we did SFA, we did POP, can improve perineal if needed, so we can stop. Who wants to stop? Who wants to go retrograde for distal access or so on? Who considered the patient a no-option patient and said, okay, let's do a DVA? Again.
And also, like green, yellow, red, and you raise your hand if you want to try to go for the peroneal.
Okay.
Peroneal.
Peroneal, green, stop, no red. Okay, no red, so no DVA. Someone decide for retrograde. Who said retrograde?
Do it, please.
Okay.
Where would you puncture?
Where?
I mean, can I just comment on DVA, guys? If you're seeing, there's a very microvascular disease. It's a very sad foot. I mean, like
Disease is sad, not MAC or not high level, no high grade of MAC, but for sure it's sad.
Well, I would suggest after treating at first femoral popliteal lesion, then the contrast dye would be better to see in the foot. So after this control angiogram, perhaps you can seek for some new arteries that you can puncture also from distal access.
Okay?
That would be my suggestion.
Okay, it could be a good suggestion.
I mean, yesterday Gonzalo Cabral was saying to inject 60 milliliters of contrast in the common femoral to get the proper picture of the foot. That's something
But
that,
here is even possible to go in the pop or to inject through the perineal, so there are more chances to pretty well evaluate the distal
I'm
anatomy.
just saying that if you want to do that, you need to pump the right amount of contrast in the peroneal.
Yeah.
You pump like in the popliteal 10 milliliters of neat contrast in order to see that potential target. It's very important to be selective and to pump like the right amount of contrast.
Yeah, fully agree. So let's show what I did. I try a retrograde first metatarsal artery access. Believe me, if you cannot see, but there is a small calcification at the first toe. And believe me, I punctured the artery multiple times, but I never deploy the wire. So no O14, no O18 guide wires could enter in this artery. And I will show I punctured the artery finally because you will see the bleeding after this. So perineal, super selective angio, road mapping, and extreme transcollateral. This is Fielder FC guide wire, engage a tarsal artery, did multiple go around, and finally finish in the median plantar. I was expecting to be median plantar and up in the median plantar. So, yeah, it was median plantar, small catheter, 1.52 millimeters balloon catheter, no super catheter in this case, even if it can be very useful, something like Carnelian Tokai, CXI, etc. And retrograde recanalization of median plantar with the fielder. Push and in.
Can
Yep.
we stop 1 second? But did you treat the peroneal on the top or not?
Right now, I use the perineal to cross. The idea was, if I finally fail, I will treat the perineal too.
Yeah, but I mean, from my point of view, in a safer environment, if you now destroy this collateral because you're super skilled, okay? There's no doubt about it. But if anyone of like, say, average clinician try to perform this transcollateral at home and you destroy that collateral, then I think you're in deep trouble.
Well, yes and no. We must to save the collaterals, always. I think this is a rule, it's a good rule. It's like when we have been discussing about common, profunda, and femoral and superficial femoral artery. It's always good to try to avoid any complication or to damage the collateral. Specifically, from my perspective, we must to think about what we need. I was considering this not enough for the treatment, and there were multiple collaterals. So the risk exists, for sure, fully agree with you. It's important to choose the proper guide wire, fielder, very soft. It's important to use nitrate to avoid any type of spasm that could follow you in a dissection. And yeah, do a good mapping.
Because I think, like, you know, the Wundosome thing. So if you were able to measure the perfusion at the level of the ulcer, and you dilate the whole peroneal with all the collaterals, I think in this case, for example, could be a very good option to see, you know, do I need to do something more or not? Because now we're going for personal experience and personal skills.
Yeah, for sure. We don't have a cutoff and a dedicated methods to say this is enough or this is not enough, so we continue following the anatomy. In the meanwhile, you can see the retrograde wire. This is in the median plantar for sure, and the antegrade second wire that engage some branch. Can go ahead with the video. Some branch of the median plantar, and to our knowledge, I found a connection that exists in most of the patients between the median plantar, the arch, and from the arch I went into the lateral plantar. So I finally succeed, this is again Terumo wire, a small balloon, succeed to go retrogradely from the median into the lateral and finally into the posterior tibial. And finally I realized a new anatomical variation, a very distal plantar bifurcation. Look, plantar bifurcation is usually more proximal, but in this case was very distal. So pass the wire retrogradely, for French catheter, pass a new antegrade guide wire in the arch, in the distality and in the arch, and start to dilate. The 2.5 Oscar balloon was good, allowed me to arrive close to the arch, and finally you can see both guide wires from median, from lateral, no dorsalis pedis. The Oscar balloon was not able to pass here for, again, spot calcification. So we did the angioplasty in the lateral plantar and in the posterior tibial at 2.5. We tried with a small high-pressure balloon. We were not able to dilate this specific calcification. And finally, this was our last result, our final check. You can see median plantar functioning, lateral plantar functioning, the bleeding in the first metatarsal artery. I punctured it a couple of times. And residual stenosis in the arch, but a clear improvement for the perfusion for all the foot, as well acceptable flow in posterior tibial, in peroneal, without any loss of collaterals. Some arteriovenous fistula, I don't think so. This is a fistula, it's a connection between the lumen and the vasa vasorum related to the subintimal progression. But finally, we succeed. So, in conclusions, Oscar supercatheter or Oscar catheter appear a very useful device for crossing and dilating BTK-BTA arteries. From the technical perspective, we still need multiple techniques to finally succeed and to manage BTK-BTA arterial disease. And again, calcium in the distal arteries, in the small arteries, are still the biggest limitation in distal revascularization. Thank you, guys.
Just a simple question. How long did it all take? How long?
2 hours, 30 minutes.
Patient awake or asleep?
Patient? No, awake. I did it during a live case 1 week ago. So yeah, it took a bit more than the normal case because I needed to explain and so on. But yeah, usually 2 hours.
Very, very nice.
Thanks.
Thank you very much, Mariano.
Thank you
Very much.